Montserrat Marron is a bioengineer graduated from the Autonomous University of Baja California with a background in microbiology and biomedical engineering. She is currently enrolled in a master's program in engineering, where her goal is to develop an auxiliary method for early diagnosis of osteoporosis using convolutional neural networks. She is passionate about the integration of artificial intelligence to assist healthcare professionals in providing more accurate and earlier diagnosis by identifying recognizable patterns in patients before their condition progresses. Early diagnosis is her goal, and she plans to continue working toward it in the future. I give the floor to Montserrat Marron.
Hello, good afternoon. Hello, good afternoon to all the speakers and guests. I'm very happy to join you all today. My name is Montserrat Marron Castillo. I'm a bioengineer and I'm currently pursuing my master's degree in engineering at the Autonomous University of Baja California. I'm here today to talk to you about the project my research advisors and I've been working on, which is artificial intelligence-based image processing for osteoporosis detection in panoramic radiographs. My research interest lies in the medical field and how we can assist professionals to achieve a faster and more precise diagnosis. First, we have to talk about osteoporosis. Bone is constantly in a state of remodeling, whether due to a fracture that needs to be repaired or under hormonal stimuli. Remodeling occurs in 4 phases: activation, resorption, reversal, and formation. The imbalance in this process is what causes osteoporosis. If the resorption rate is greater than the formation rate, bone density decreases. We can classify osteoporosis into 2 categories: primary osteoporosis, which includes idiopathic and involutional osteoporosis. Idiopathic osteoporosis affects patients of all ages and both sexes, and involutional osteoporosis is divided into 2 types: type 1 or postmenopausal and type 2 or senile osteoporosis. For secondary osteoporosis is related to or caused by other diseases or medications. Likewise, this classification of osteoporosis can also result from chronic diseases, malnutrition, certain medication, or immobilization. Osteoporosis is not the most common disease, but it is of global concern due to its morbidity. In 1994, the World Health Organization established the diagnostic criteria for osteoporosis in Caucasian postmenopausal women using the T-score. The T-score is the number of standard deviations compared to the bone mass density of the young population of the same sex and is obtained from bone densitometry. Treatment, like diagnosis, differs depending on the type of osteoporosis. For primary osteoporosis, the drugs used are divided into 2 types. Type 1 is anti-resorptive agents, and type 2 or anabolic agents. Anti-resorptive agents focus on preventing bone resorption, and anabolic agents increase bone formation. For secondary osteoporosis, the treatment focuses on addressing the underlying cause and eliminating the adverse effect, leading to low bone density. For prevention, special emphasis has been placed on nutrition and exercise. Calcium and vitamin D have been shown to be the most important and key nutrients in preventing osteoporosis, while exercise and an active lifestyle can also help us prevent this disease. On the other hand, alcohol intake and smoking are 2 harmful habits that can affect the bone remodeling process. Now, the search for an efficient, non-invasive, and accessible diagnosis for osteoporosis has led various researchers to explore alternatives for osteoporosis diagnosis. Over the years, one method that has gained popularity and relevance is the mandibular cortical width and the mandibular cortical index. Considering that osteoporosis affects all the bones of the skeleton in a generalized way, it was concluded that it also affects the mandible. Fortunately, the mandible can be easily and non-invasively observed through panoramic radiographs, making an appropriate reference for osteoporosis. The mandibular cortical width is a strip of cortical bone located at the lower part of the mandible, which appears as a band of cortical bone. By studying osteoporosis and comparing it with the mandibular cortical width, it was established that a mandibular cortical width measurement less than 3 mm is associated with a high risk of osteoporosis. The mandibular cortical width measurement follows a specific methodology proposed by Wickel and Swoop. First, the mental foramen must be located and taken as a reference. The mental foramen is an anatomical structure through which the mental nerve and the corresponding blood vessels emerge. This structure is often the most difficult to locate in some patients. Second, a line is drawn from the mental foramen to the lower border of the mandibular cortical width, forming a 90-degree angle. Finally, the measurement is taken from the lower to the upper border. Another characteristic associated with osteoporosis is the mandibular cortical index, the mandibular cortical index. It has been observed that during the progression of osteoporosis, porosity and resorption occur in the mandible. When resorption occurs, porosity is observed on the mandible. Three classification has been established. C1 is a normal mandibular cortical index where the bone is in a healthy state and the upper border appears smooth and well-defined. C2 is when we can see a few radiolucent areas with different shapes. The border appears moderately porous and it represents a medium risk of osteoporosis. And C3 is when where the bone shows severe damage with severe linear resorption and porosity is observed at the border, and it represents a high risk of osteoporosis. As we discussed, the mandibular cortical width and the mandibular cortical index can be seen in panoramic radiographs. Panoramic radiographs are the most commonly used studies by dentists and maxillofacial specialists as they provide valuable diagnostic information and are affordable. These radiographs use a low amount of radiation and are taken about 12 to 15 seconds, so they are practical studies for the search of osteoporosis, compared to the traditional densitometry. Okay, now, to automatically classify the porosity based on limited areas of interest and take millimeter measurements, the traditional image processing has been overwhelmed by this task. For this reason, convolutional neural networks has been used to accomplish this process. In recent years, authors have focused on classification, categorizing images into 2 to 3 porosity levels, while automatic measurement of the mandibular cortical width has not yet been fully achieved. Although the results are promising, further experimentation is required to increase accuracy. Convolutional neural networks are networks designed to mimic or simulate human neural activity to recognize patterns and objects in visual data such as signals and images. In images, convolutional neural networks are used for categorization and segmentation. These types of networks are a subtype of neural networks that use convolutional layers for feature extraction, and then use interconnected layers of neurons to perform classification based on the extracted features. Various models have been specifically used for osteoporosis detection through porosity classification. AlexNet, BGG16, and GoogleNet have demonstrated the best results. Some authors have opted to use only 2 porosity classification, as I mentioned, osteoporotic and non-osteoporotic instead of 3. This is because of the difficulty of perform training of 3 classes with a limited data set. Okay, now with that being said, we can move on of the case study. The Dental Outpatient Clinic of the Autonomous University of Baja California provides 2,255 panoramic radiographs, taken in 2 different locations using a 9,300 Pax-Batec, a 9,300 Carestream system, and a Pax-Batec in Mexicali, Baja California. From these studies, only the images were used, leaving out the personal data of the patients. From this data set of 2,255, the 401 images with the clearest mental foramen were selected to begin the prototype. These 401 with label image using 2 classes, mental foramen and mandibular cortical width. The images were cropped and both the right and the left halves of the mandible were used and each treated as an individual image. YOLO version 7 was used, leveraging the pre-training weights of the model for transfer learning. The training parameters are shown in Table 2. We select 100 epochs, a batch size of 10 images, an image size of 320, and the training was performed with the graphic processing unit. Some of these parameters were chosen due to the equipment limitations. Nevertheless, the training session was successful. The hyperparameters are presented in Table 3. These hyperparameters were found to be the most influential hyperparameters in various studies focused on radiographs. Now, with the trained network, we applied the network to the dataset of 2,255, and the detected mandibular cortical width crops were saved, yielding a new dataset of 2,939 images of different sizes of the region of interest I mean the mandibular cortical width. With this new dataset, we classify manually. Specifically, 1,167 classify as C1 using 1,067 training images and 100 validation images. 1,210 classify as C2 using 1,110 training images and 100 validation images. And 562 classify as C3 using 517 training images and 45 validation images. With this classified dataset, a new convolutional neural network was constructed. It was specifically a 5-layer convolutional neural network. This 5-layer convolutional neural network was experimented alongside a BGG16, yielding similar results. Therefore, to reduce computational costs, the experimentation continued with the simple 5-layer network, which provided the best results. Once the training was complete, a Python code was created that reads the entire image, crops it as mentioned before, detects the mandibular cortical width and the mental foramen, processes the mandibular cortical width to extract the edges, and measures the mandibular cortical width. The output consists of the mandibular cortical width measurements and the porosity classification. It can be concluded that the system is functional with promising results, although a larger number of images is required for further experimentation. The results in terms of segmentation are as follows: an accuracy of 0.58, map 0.5 of 0.45, and a F1 score of 0.53. For classification, an accuracy of 71% was achieved, and F1 scores of 0.78, 0.64, and 0.64 were achieved for C1, C2, and C3, respectively. Now, we can observe the classification and the measurement process of 3 different patients. For patient 1, we can see the full radiograph. We crop the image to work with the right and with the left sides of the mandible. We apply YOLO to detect the mandibular cortical width and the mandibular cortical width and the mental foramen, and then we classify the porosity with the mandibular cortical width crop. This patient is classified as C1. Then, with the mandibular cortical width crop, we process and apply the Howe transform to determine the edges. And then we drew the perpendicular line from the mental foramen to the lower border of the mandibular cortical width. The measurement in this case is 4.26 millimeters and 4.37 millimeters. For the patient 2, the same process applies. We crop the image, classify, this patient is classified as C2, and we measure. The measurement is 4.25 millimeters and 5.29 millimeters. And in the case of the patient 3, as we can see, we have a resorption. So this patient is classified as C3, and the process stopped because C3 represents by itself a high risk of osteoporosis, and measurement is not possible due to the porosity of the upper border. In conclusion, we obtain a functional model that has the potential to streamline osteoporosis diagnosis. Although, in terms of accuracy and F1 score, it can be greatly improved by integrating more images into the dataset. Label imaging and obtaining quality image from medical imaging is one of the most complicated tasks when working with artificial intelligence in the medical field. We believe that by integrating the porosity classification and the mandibular cortical width measurement, we achieve a more accurate diagnosis as we complement the risk of osteoporosis based on the porosity with the mandibular cortical width measure established and the T-score. Our contribution to this area of work was the implementation of segmentation based on YOLO, and we believe that based on this project, we will gradually achieve a more accurate diagnosis until we can implement this method as a routine examination to visualize bone health. Thank you.